So I would now like to turn it over to our chair of NCCRT, Dr. Steve Itzkowitz.
Thanks so much, Caitlin, and thank you everybody for joining us. We're really excited. This is a maiden voyage for us. This is the first time we're launching this Blue Star Conversation series. In case you don't know, the Blue Star Conversation series was born at the last year's annual meeting in November, where we had a session on a particular topic or centered around disparities for colon cancer screening. And following that, we had breakout groups. And there was a lot of engagement. There was a lot of great ideas. There was a lot of interaction. So unlike many other webinars of this kind, what we're trying to do here is reproduce that. So take a topic and have people really engage in conversations in breakout groups afterwards. And so today's Blue Star Conversation is being hosted by one of the NCCRT strategic priority teams, and that is the Family History and Early Onset Colon Cancer SPT, Strategic Priority Team. And what we really want to do today is to understand some of the latest research on how preventable early onset colorectal cancer is, and really to explore possible strategies and opportunities to try to prevent this from happening. And we'll get into some questions related to that in the breakout groups. It's also an opportunity to meet some of the NCCRT members and other people on this call, bring together folks from comprehensive cancer coalitions, the CDC, CRCCP, really our larger NCCRT community. So we're really, really thankful that you could join us. I'm quite convinced that this is going to be very informative, and we certainly welcome your feedback afterwards as to how this went and what topics what topics you'd like to hear about moving forward. But at this point, I want to turn it over to one of our chair for this session, and that's my good friend Paul Schroy, who is co-chair with Heather Hampel of the Family History Early Onset Colon Cancer Strategic Priority Team. So Paul.
Thank you, Steve, and good afternoon, everyone. We thought that these conversations provide an excellent opportunity to shed some insight into the work of the Roundtable's various strategic priority teams. As many of you may know, the Family History Task Group was founded in 2012 and later expanded to include early onset colorectal cancer in 2014, largely due to the efforts of the late Tom Weber and late Dennis Onen. We are then either rebranded or renamed as a strategic priority team in 2020. And our charge has been to identify key issues and areas of need around familial and early onset colorectal cancer for the purposes of identifying opportunities for the Roundtable to be a catalyst for change. Next slide, please. So much of our work over the past decade has been guided by this following set of themes or objectives. First, to help clinicians develop a system-based approach to the identification and management of patients at familial risk, as well as the recommendation for early diagnostic evaluation of those presenting with signs or symptoms of colorectal cancer at any age. Then to improve the functionality of the electronic health record to facilitate needed screening and/or counseling recommendations for patients with a family history, to increase clinician, patient, and intrafamily communication about familial and inherited risk, and to address the increase in colorectal cancer in young adults through strategic planning and interactions with key stakeholders and thought leaders. And lastly, and most relevant for today, is to improve on-time screening according to the recommended guidelines for both average and high-risk individuals. Next slide, please. So this slide lists many of our accomplishments over this past decade. I'm not going to review them in any detail. I just put them up there to see that we've actually been quite busy over the years, and feel that we have accomplished a lot towards those goals and themes. Next slide. So today's discussion will focus on a recent study that provides new and compelling evidence supporting the importance of on-time screening. Thus, without further ado, I'm thrilled to introduce our presenter, Heather Hampel, who is the co-chair of our strategic priority team and served as a co-investigator on the study of interest. Heather is also a professor in the Department of Medical Oncology and Therapeutics Research and Associate Director of the Division of Cancer Genomics at the City of Hope National Cancer Center. Heather, you're on.
Thanks so much, Paul, and thanks to Fight CRC. No, not Fight CRC. Our friends are at Fight CRC too, but to the National Colon Cancer Roundtable for organizing this event today. It's always nice to, pay special attention to colorectal cancer this month during Colon Cancer Awareness Month. So before I start my talk, I want to just put a disclaimer out about the title, and that is we're going to talk about if everything was working perfectly in all of our healthcare systems in terms of taking a family history and making the proper recommendations for screening, and if people were referred to genetics and had genetic testing at a young age, like in their late teens, 18 to 20, what colorectal early onset colon cancers could be prevented. And this is by no means to, say that somebody has made a mistake if they had a colon cancer that was not able to be prevented. It's to say that we need systemic changes to prevent the ones we can. So we know that some people with early onset colon cancer do have a family history of colon cancer. And if someone had taken that family history and told them to start their screening earlier, perhaps they could have prevented their cancer. Similarly, some people who get early onset colon cancer have a hereditary cancer syndrome. And if someone had taken their family history and done genetic testing and gotten them a diagnosis early enough so they could start their screening earlier and younger, they could have potentially prevented their cancer. And so what we're trying to get at here is that we know the incidence of early onset colon cancer is increasing, and we don't know all of the causes yet. And all of us are very busy trying to figure out what they are. And many of them are not family history or genetics. But the ones that are due to family history and genetics are the ones we could potentially prevent now if we all worked hard to raise awareness, education among providers and the public so that people could get screened at the proper age. So on-time screening, as Dr. Choi mentioned. So that's what we're going to be talking about here today. Next slide. Also, my Twitter handle was there at @Hampel1. I've been doing a tweet a day this month for Colon Cancer Awareness Month. So if you aren't following me yet, please do. I do have some disclosures. I'm on the scientific advisory boards for a few genetics companies and do collaborative research with a few as well, but none of those relationships will affect the content of my talk today. Next slide. Okay, so we did a very large study in Ohio called the Ohio Colon Cancer Prevention Initiative. And one of the early studies we published was looking at the first 450 patients who were enrolled in that study who were diagnosed under age 50 and what % of them had a hereditary cancer syndrome. And I'll never forget the first time I presented that to Dr. Dennis Anand. He said, well, how many of them had a first-degree relative of colon cancer, Heather? And I said, oh, let me look. And so we knew at that time 16% had a hereditary syndrome, 14% had a first-degree relative of colon cancer. And he said, well, how many of them had a first-degree relative with an advanced polyp, Heather? And I said, actually, we didn't ask about that. We should see if we can figure that out. But he was the first one who sort of drew my attention to the fact that there was a sizable proportion of these patients who, if everything was working properly and knew about their risk and were told to screen at the proper age, we could have potentially prevented their cancer. So we decided to actually dig into this a little bit further. And so with one of our genetic counseling graduate students, we formed a project at the end of the study. So all told, we had at this point 713 total cases out of the 3,300 that enrolled in the study overall. There were 713 who were diagnosed under age 50. And just to let you know, this was very population-based. We enrolled patients from 50 different hospitals throughout the state of Ohio. The only eligibility criteria was having a diagnosis of colorectal cancer. No age criteria, no family history criteria. So when we started digging into this further, we had to say, okay, well, we know 16% had a mutation in a cancer gene, but how many of them even have an increased risk for colon cancer, where if they had known about it, they would have started their colon screening younger and done it more frequently. And so we narrowed it down to the mutations in genes that have established colorectal cancer screening guidelines. And so 83 of the patients had a mutation in one of those genes, so 11.6%. So while it was 16% total, clearly around 4.4% were in genes that didn't have colon cancer risks or colon cancer management guidelines. So these 11.6% did. So that included 63 individuals with Lynch syndrome, and you can see the mutation breakdown here, 10 with familial adenomatous polyposis, 6 with MUT-YH associated polyposis, 3 with CHEK2, which is a moderate risk breast colon gene, but it does start colon screening earlier, more frequently at age 40 and every 5 years. 1 SMAD4, that's a juvenile polyposis gene, and 1 BMPR1 alpha, which is also a juvenile polyposis gene. So all of these individuals had a hereditary cancer syndrome for which colon cancer screening should start much earlier and occur more frequently. So we said, okay, well then how many of the 713 had a first degree relative with colon cancer? And that was a total of 97, or the 14%, 13.6% had a first degree relative with a colon cancer, but 33 of those individuals also had a mutation in one of the colon cancer genes, because of course the individuals who had a first degree relative with colon cancer were more likely to have one of the hereditary colon cancer syndromes. So we didn't want to double count individuals. So we removed those 33 to come up with the total additional individuals who could have started their colon cancer screening earlier and been advised to do it more frequently, either based on family history or based on a genetic diagnosis. So that's an additional 9% of individuals there. So 20.6% total. And that left 79.4% of our cohort with presumably sporadic colon cancer. So they at least did not have a first degree relative with colon cancer, and they did not have a mutation in any gene that has colon cancer management guidelines. And we know that because we actually did a pan-cancer panel on all 713. So, this means the vast majority are not hereditary and do not have a family history that would start screening earlier. And of course, we need to figure out what's going on with that cohort as well. Okay, so it looks like we've advanced. So this means that about 1/3 of early onset colon cancer is potentially preventable through the use of family history and genetic testing to start on-time screening. So here's the 11% with a hereditary cancer syndrome, the 9% with a first degree relative with colorectal cancer. And we don't know what percent also had a first degree relative with an advanced polyp. But Dr. Anand said, well, it has to be at least as many as have a first degree relative with colon cancer, Heather. So just throwing that in here with a big asterisk, that would mean that potentially 29% of early onset colon cancer patients might be preventable if we had systems that were working better to identify individuals who had a family history, get genetic testing, start screening at the right age and right frequency. So let's look a little closer. Next slide. So what we did was we knew the age of these individuals' relatives when they were diagnosed, and we knew what gene their mutation was in. So we were able to, for each of these individuals, indicate at what age they should have started colonoscopy if we had known about their family history and given them the proper on-time screening message, or if they had known about their mutation and had been given the proper on-time screening message. So looking at both the mutation and the NCCN guidelines for that mutation in terms of when screening should start and how frequently it should go. First degree relative with colon cancer, also using NCCN guidelines. And then we also looked at, the new ACS guidelines to start screening at 45 and how that might have helped this cohort. We consider the colon cancer potentially preventable if their screening would have begun 5 or more years prior to their age of diagnosis of their early onset colon cancer. We considered that it would have led to an earlier diagnosis, potentially downstaging the cancer, if the screening would have begun 1 to 4 years prior to their age of diagnosis. And we considered that it would neither have been prevented nor diagnosed earlier if screening would have begun at or after the age that they were diagnosed with their colon cancer. Next slide. So looking at the hereditary group first, so there's 83 patients here. Their mean age of diagnosis was 42, ranging from 20 to 49. Of course, everyone's under 50 here, so 49 is going to be the high end. And screening would have begun a median of 18 years prior to their colon cancer diagnosis if they had known about their hereditary cancer syndrome. So the screening guidelines for hereditary cancer syndromes appear to be very effective and would have worked well if these individuals knew they had a hereditary cancer syndrome. 81 of the individuals actually, which is 97.6%, would have initiated screening prior to their diagnosis. 74 would have been 5 or more years prior to their diagnosis, and the cancer would have been potentially preventable. 7 or 8% would have been diagnosed earlier, so in that 1 to 4 year range where it could potentially be downstage. And only 2 of the cases would neither have been prevented nor diagnosed earlier. And on the next slide, you can see a waterfall plot which shows how many, for each individual, how many years prior to their colon cancer diagnosis they would have started screening if they had known about their genetic mutation. And so you can see all the people in green would have known about their colorectal cancer diagnosis, or about they would have started their screening many years before their colon cancer diagnosis. Only 1 would have been after, and 1 was diagnosed at the same age that they would have been recommended to start. So that one would not have been prevented or diagnosed earlier. So those are the 2. Next slide. Now we'll look at the group that had a family history risk. So they had a first-degree relative with colon cancer. So these were very different because we had to look for each case, because the guideline is that you start at age 40 or 10 years prior to the earliest diagnosis in the family, the diagnosis of your first-degree relative. So we had to look at the age of their first-degree relative, and if that would have had them start before 40, we indicated the exact age they would have started. If it would have had them start at 40, we indicated 40. And so the median age of this group was 45, also ranging from 20 to 49. And these guidelines did not start screening so much earlier than the age of diagnosis. Screening would have begun a median of 7 years prior to the age of diagnosis. But a full 80 or 82% would have been initiating their screening prior to their age of their colon cancer diagnosis, with 65 being potentially preventable because they would have started 5 or more years prior to their age of diagnosis, and 15 being potentially diagnosed earlier. So they should have started about 1 to 4 years prior to their age of diagnosis. And about 17 or 18% would have neither been prevented nor diagnosed earlier, even if we knew about their first-degree relative and told them the correct age to start their screening and they had done it. And the waterfall plot on that's on the next slide. So here you can see, there were more patients who would have started their screening at or after their age of diagnosis, as indicated in red. So those are the cases that we couldn't have prevented or diagnosed earlier. And the cases that are less than 5 years here are the ones that would have only been diagnosed earlier or potentially downstage, but all of these would have been potentially prevented, all of the ones that were at 5 years or more. Next slide. So we also looked at a guidelines that is used to in Europe, which is that if you have a first-degree relative with colon cancer, they start at 40 and go every 5 years, only if the first-degree relative was diagnosed under or at age 60. And that obviously missed a lot more of these early onset. So this is a guideline that's more common in Europe. Some professional organizations still use this guideline. So they only recommend colonoscopy beginning at 40 and every 5 years if the first degree relative is diagnosed at 60 years or younger. And you can see it prevented and potentially diagnosed earlier far fewer cancers than the NCCN guidelines that we usually use in the United States, which is for any first degree relative with colon cancer at any age, we start at 40 or 10 years prior to the age of diagnosis, whichever is earlier. Next slide. We looked at the sporadic group. So this is the group without any family history or any hereditary cancer syndrome. Their median age was 44, a lot older, obviously, and they range from 17 to 49. So we had a 17-year-old who did not have a hereditary cancer syndrome or a first degree relative with colon cancer. And with the new ACS guidelines to start screening at age 45, obviously that's within 5 years of anyone's diagnosis on this study, but a full 41% would have initiated screening prior to their age of diagnosis, and all would be in that potentially, diagnosed earlier, potentially downstaged group, because obviously this is starting at 45 and we only looked till age 49. And 58.7% would neither be prevented nor diagnosed earlier. But I think we know a lot of the early onset colon cancer does happen in that age 45 to 49 age group. And so moving back the guideline to start at 45 should be very, very helpful for a lot of people. And then obviously people who would have been diagnosed at 50, 51, 52, 53, 54 are potentially preventable, but they weren't included in this study. Next slide. So the overall results are that 20.6% of early onset colon cancer patients have either a mutation in a gene that has colon cancer screening guidelines that are increased, or they have a first degree relative with colon cancer, which means they need earlier and more frequent colonoscopy. In total, 16.4% of early onset colon cancer patients in our cohort then were potentially preventable. In other words, if we had done all this and started their colonoscopies at the proper age, their screening would have started 5 or more years prior to their age of diagnosis. That's 74 of the 83 cases with a mutation in a gene with colon cancer guidelines, and 43 of the 66 cases with a first degree relative with colon cancer. Next slide. I think just like some overall conclusions here are that while 16% of early onset patients have a mutation in a cancer susceptibility gene, only about 12% or 11.6% are in genes that have colon cancer screening guidelines. About 9 to 14% of early onset colon cancer patients in our cohort had a first degree relative with colon cancer. And this just depends on whether you include the ones who have a mutation or not in your count. And in total, 16.4% in our cohort could have been potentially prevented if we were doing a better job of genetics and family history-based screening. The surveillance guidelines for hereditary colon cancer were more effective than those for those with a first degree relative only. We could prevent far more of the cancers in the hereditary group, but they're much more aggressive, starting at 20 and going every 1 to 2 years in a lot of cases. And the surveillance guidelines for people with a first degree relative with colon cancer are more effective without an age requirement for the first degree relative. Again, potentially preventing 82.5% versus, or earlier diagnosis for 82.5% versus 51.5%. And the new ACS guidelines, which luckily have now also been adopted by USPSTF, could result in an earlier diagnosis for 41% of our early onset cases, and obviously could prevent an untold number of cases because we didn't look at the cases that were diagnosed in the early 50s in our cohort. And that is what I've got for you guys today.
Groups hit on a lot of important topics. I'm sure there was a consensus that Heather's presentation is certainly provocative and compelling. There seems to be consensus around the importance of lead time messaging. And to that end, the Roundtable has convened a working group to identify, in collaboration with a market research team, to come up with some pithy targeted messaging for the 20 to 45-year-old age group. And the consensus there is that we'll probably need multiple messages targeting different age groups within that interval, just because things will resonate with a younger patient that may not resonate with an older one. So that is ongoing, and from the discussions we just heard about, that might be very valuable to a number of the participants in this meeting here. And then I just put a plug in again about our risk assessment and screening toolkit, which is quite comprehensive. Mary Dorshank mentioned that one of the shortcomings is it targets colorectal cancer, but it's certainly valuable in just sort of getting an overview of what the challenges are and how you might address them in an office practice. So again, that's something useful. And then, we have these issues around quality and insurance coverage, which are hot ticket items. But overall, I think there was a lot of, important discussion that went on. It sounds like this is on everybody's radar screen to some extent, and that we encourage everyone to, continue doing what you're doing, and hopefully we can establish some collaborations going forward. and areas of interest for the members here. So I want to thank Heather for her presentation. I want to thank everyone for participating in today's discussion. It was a first try, and I think it worked. Like these things, we tend to run over, but we did a pretty good job sticking to the schedule. And I encourage everyone to fill out the survey that you're going to receive at the end of this meeting. It's a brief survey, but your feedback's incredibly valuable to us. So again, thank you everyone for your participation.